Hey Nisig, my name is Crystal Fever. I just wanted to give a quick introduction to our third guest speaker for the Ask Me Anything series, Dr. David Abbasi. I first met Dr. Abbasi when I was doing my sports physical therapy residency in Houston, Texas, where he served as a mentor of mine. To this day, he continues to be a great friend and teaches me a ton from afar, and I thought he would make for a great guest for this series. He currently practices down in Florida, and he is a double board certified orthopedic surgeon in both orthopedic and sports medicine. Down in Florida, he serves a large amount of the mixed martial arts community and combat sports community, and serves as a ringside physician for a variety of different cage fights, including the UFC. He has a specialty in arthroscopic surgery, specifically of the knee, shoulder, and elbow. And is a great guy to learn from, and I think will offer a lot for us here today on the topic of the posterolateral knee. So thanks to those who submitted their questions. I'm excited to introduce you to Dr. David Abbasi.
So the next question I was asked was, what high priority structures do I try to identify on a dissection in the knee on the posterolateral corners? That's a great question. Because when you have an injury, all the damage can be different going from knee to knee. You want to start with something and be comfortable with something that you know is going to be there. So I usually, use my fibular head as kind of like the lighthouse. Now, you gotta know your anatomy in terms of the layers of the knee. So starting superficially, you're going to have that, on the outside or lateral aspect of the knee, you have the IT band and the biceps tendon. Superficially, that's layer 1. And you're going to have your common peroneal nerve posterior to the bicep, and that can commonly be injured during these injuries. You can have patients with foot drop on the more serious ones, but that's layer 1. When you go deeper to that, you're going to have your retinaculum or patelloretinaculum and your lateral patelloretinacular layer, and then deep to that, you're going to have your LCL, and doing operations on the lateral aspect of the knee, I've always been surprised how thin the LCL is when you look at it. It's like a little spaghetti string. So what I use is the fibular head because I know it's going to be there, and then I work superiorly to that or proximal to that. And usually when you're dissecting, you can see very clearly the first layer, the biceps tendon and the IT band. Sometimes those can even be avulsed off. But then you'll feel that second layer, and sometimes you can feel with your finger the LCL below that. So that's what I find my fibular head, and then I know just proximal to that the LCL should be coming down, and that's where I make my split of that layer 2 to find my LCL, and then I use my LCL to then go ahead and find the popliteus tendon, and we know that that's antero-inferior on the knee. So that's how I do it, doing a few of these. Starting with layer 1, working my way down, get past the IT band and bicep, then you're down on layer 2. Deep to layer 2, the LCL should be there. How do you find the LCL? I use the fibular head or the bone. And then again, I'll see if I can feel the little squiggly LCL. If it's been avulsed off the fibula, I'll make my split in layer 2, find the LCL, and then use my LCL to find my popliteus tendon. And again, deep to that, the popliteus tendon is going to be intra-articular, so you'd have to make a split in the capsule. But that's how I do it. And the popliteus tendon as well, if you're scoping the knee, will be found on the arthroscopy. And you can see if there's injury there. But if it's avulsed off, you'd have to find it and repair it from the lateral approach. Hey guys, we're here with a traumatic lateral-sided knee injury. So I'm going to take you through here. So let's take a look at the wound. We got our incision here on the lateral side of the knee. So let's put some wheat laners in here. Take a look at some of this anatomy. So we can see here, this is the hamstring bicep tendon here that avulsed off of this fibular head. Additionally here, we have, this is the LCL of the knee avulsed as well off of the fibular head right there. Another anatomic structure that's been popular lately is the because this is the biceps femoris, we know that the common peroneal nerve is directly behind that or posterior to it. So if we come down here, this is that common peroneal nerve here, right here. So you can see how superficial or close to the skin it is here. So we're trying to find our attachment site on the fibular head. So I'm going to clear off some muscle off the proximal fibular head so we get a attachment site to repair the LCL and the biceps femoris tendon back down to the bone. So I'm going to use my Bovie here, start lifting this muscle. So I know, my nerve is protected back here. The common peroneal nerve is posterior to me or behind me, so I'm good there. And I just want to expose a little bit of this fibular head because that going to give us a strong anchor site to repair the torn structures back to bone instead of poor tissue. So the next question I was asked prior to imaging like an MRI, what are some of the best physical exam maneuvers that I like to use to check the posterolateral corner of the knee? So I would say, just starting simple, just doing a varus stress test with the knee in 30 degrees or, 15 to 30 degrees. If you're getting that laxity laterally with the varus stress, the lateral structures are injured, and usually those are injured together. But if it's opening up laterally with the varus stress, I know that LCL is likely torn. And then we'll go to more rotational type tests like a dial test. So, doing it at 30 degrees, you're checking for that popliteus tendon if it externally rotates more than the contralateral side. And then if you're doing it able to get more rotation at 90 degrees, then we're more worried about the PCL as well. So PCL can also be injured with the posterolateral corner. So, even always check your lockman, check your posterior drawer test, and then those rotatory tests, and then that varus stress as well. And don't forget to check for that common peroneal nerve. Make sure they don't have a foot drop, because if you have a posterolateral corner injury, a lot of times, not only did the ligaments get stretched, the capsule gets stretched, but that common peroneal nerve got stretched and sometimes can have a palsy. So you don't want to miss that. So make sure you're doing, checking for dorsiflexion of the ankle as well. So the next question I was asked, broadly speaking, what are some of the major restrictions that I want after a posterolateral corner repair or reconstruction? So just keeping it simple, I would say, making sure the patient stays in their range of motion brace, because really what's going to hurt us is the varus valgus stuff. I don't want them on the opposite hip, doing any abduction type stuff. Basically want to avoid any tension to the repair on the lateral side. So avoiding that, as long as they're staying in their knee range of motion brace, and then if there's any other injuries like the PCL and stuff, making sure we protect that, or an ACL, stay away from early open chain stuff, just like, our basic principles. But as long as they keep that knee brace on and avoid that varus valgus, or anything that's gonna, put tension to the lateral side, broadly speaking, that's what we want to really avoid, especially in the first 6 weeks when most of the healing is happening. So when we're talking about what are the reconstruction techniques, I was asked about, using soft tissue versus Achilles bone block and stuff, and what the differences between that are. I would say I'm not aware of any differences in the literature. One is necessarily better than the other, so it probably goes back to surgeon preference and experience. I'll say my personal technique, I'll always, if I can get to the injury early, I would prefer to repair everything, if at all possible, to try to avoid any allograft tissue. But really what happens if you can't get to these within the first 4 weeks, what you notice is when you're identifying structures, they literally start disintegrating. To do a repair of something, you got to put stitches in something, you're using anchors. And a lot of times, if they've been torn for 4 weeks, these little structures, and again, that LCL is a lot smaller than you think sometimes. It's like a little spaghetti. So at like 4 weeks after the injury, it's almost like they can't even hold a stitch, or it starts disintegrating, it starts pulling through. So the tissue quality really gets down if you can't get to a repair early. So then you have to talk about reconstruction. So personally, my technique is I use a soft tissue allograft. I make a drill hole through the fibular neck, making sure obviously to protect the peroneal nerve stuff, but make a drill hole from front to back, and then loop the tendon up and fix it basically near where the LCL femoral attachment is. And I just feel that anatomically there's tons of different techniques. You can split the tendon into two separate limbs, one for the LCL, one for the popliteus tendon. There's other techniques where you can weave it through the back of the tibia, and some studies show that you're over constraining there. So based on my experience, based on talking to more experienced surgeons, that's the technique that I do, and I think it's called the Laprade technique. It's worked well for me. I feel like it stabilizes that lateral aspect of the knee from where they're starting from. So that's what I use, but I think it comes down to just surgeon being comfortable and surgeon experience and the timing of surgery. If you can get to it early, you go for the repair. If you're getting beyond that 4 weeks, it's probably, it may disintegrate. You're not holding stitches well, and that's where a reconstruction is going to be more the best way to go. We're working on our lateral side of repair. We're repairing from the inside out. We've already repaired our LCL here with our suture anchor, with one of our sutures. Now this is our hamstring tendon that also avulsed off the proximal fibula. So I've whip stitched that hamstring tendon. As I bring that down, you can see we can get it back down to that fibular bone. So we'll go ahead and tie it down here to get a nice repair. So it's a little bit darker now. It's nighttime. Continuing on here. But the next question was, what are some of the prognostic factors after constructing a posterolateral corner on who may or may not do well, and what do I look for those prognostic factors? So I think that's a good question. I would say the biggest thing would be the alignment of the knee. So a lot of these athletes have varus alignment, as you guys probably can see. They have varus alignment of the knee, they have flat feet, and so someone who has varus alignment of their knee, they have more stretch on the lateral structures to start with, and that's what makes it kind of difficult sometimes where we're recommending surgery. So let's say they have an ACL tear or have a posterolateral corner injury. Obviously, you want to repair those structures or reconstruct the ACL, but a more difficult conversation becomes, do we do a tibial osteotomy to correct the varus alignment of the knee? And that's a tough sell, especially when the other knee has the same alignment and doesn't have the same pathology. So it's like now you're going to take one knee that's going to stay varus and make the other one neutral. That's going to throw everything off. So it's a really tough sell. It makes it definitely difficult. But I would say those patients that have the varus knees, the flat feet, that have that, almost baseline tension on the lateral side, I get more worried about, is this more likely to fail in the future? Hey guys, so the next question was, when doing surgery or reconstruction, what decision factors go into if you're going to make somebody an accelerated or a delayed protocol for physical therapy? So I guess a common example would be something like an ACL reconstruction, where we have our accelerated protocols or delayed protocols. At least for me, what helps make that decision would definitely be the if there was any meniscal repair or any cartilage repair, and for meniscus repair, for example, was it a stable type of repair, like a longitudinal tear or a horizontal tear where you get a very nice opposition of the tissue, or was it a radial tear where you're sewing something side to side that doesn't necessarily have the best blood supply? And then for anything cartilage too, we're probably going to be doing something that's delayed protocol. You're definitely not going to want to be putting any weight early on a cartilage repair or like biocartilage type procedure or Oates procedure. So a lot of times, especially for an ACL or something like that, that's not really the rate limiting step. A lot of times it becomes the meniscus or the cartilage in the knee. All right, so we're here with this patient. We're 3 months out. We did an arthroscopic medial meniscus repair, And then we also did an open LCL repair. His hamstring was torn off the fibular head as well. So we did a hamstring repair. And he also had a little bit of a foot drop, so we did a neurolysis of the peroneal nerve. So I'm going to start on the other side, just get a good sense of his varus valgus stress. Just let it relax, okay? Just let it lay on me. And we're just checking his varus here. So our LCL stops us from opening medially like that. So now I'm going to reach over and come over on this side. And bring this one back down. And let's do the same thing here. So you can see a little bit there, but pretty symmetric to the other side. And if I bring him up here, again, we'll use our fibular head as my landmark here, and I'll come up right here, and I can feel that distinct LCL right there. So, do you have any pain when I press over you over here?
None.
Not at all? All right, great. So a pretty good result, 3 months out.